Good morning. My name is Daniela Pino. I'm a third-year resident in the OBGYN department. We're going to talk about today of a rare case of autosomal recessive hereditary spherocytosis that was presented in utero as a non-immune hydrops and severe refractory fetal anemia. Our patient is a 21-year-old female. She was initially referred to the MFM service for fetal hydrops at 19-week gestation. This first ultrasound reported polyhydramnios with an AFI of 21, a very thickened placenta, cardiomegaly, hypertrophy of the myocardium with left axis deviation, and severe tricuspid regurgitation. The baby also had mild pericardial and pleural effusion. And finally, the MCA Doppler showed increased peak systolic velocity with a multiple of the median of 2.4. These are some of the pictures of the ultrasound. Here we can see the mild pericardial and here pleural effusion. Right here we'd see the MCA Doppler showing us a peak systolic velocity of 59 that we then plug into a special chart that gives us the 2.4 multiple of the median. And here we can see these jets coming down that are not normal. Those represents the severe tricuspid regurgitation. This is a clip and we can see the enlarged heart, the hypertrophy of the myocardium. Here we'll see the pericardial and here at the side pleural effusion. Let's talk about a little bit of fetal anemia. Fetal anemia can be used with hemoglobin or hematocrit values, same as in adults. Hemoglobin value that is more than 2 standard deviation below the mean will be diagnostic of fetal anemia. We have several causes of hydrops or fetal anemia causing hydrops. One of the most common causes will be red cell autoimmunization, and this will cause what is called immune hydrops. We also have what is called non-immune hydrops, which can come from several infections that are associated with anemia, particularly parvovirus B19, CMV, any of the torch infections, and also there are rare conditions like red cell enzymopathies or red cell structural abnormalities or even leukemias that would also give us fetal anemia and subsequently non-immune hydrops. This is from the SMFM clinical guidelines for non-immune hydrops, and as we can see here, cardiovascular causes includes like 17 to 35% of all the causes of non-immune hydrops. Infections only 5 to 7%, and then unknown cause remains also a high value in 15 to 25% of the cases. And this is from the same guidelines. This is the workup for non-immune hydrops. So first they recommend to do a detailed ultrasound including fetal echo and take the full maternal HMP. So we did this and we find a structurally normal heart in our patient. Even though it was hypertrophic and it had the pericardial and pleural effusion, the heart was structurally normal. So the MCA Doppler, it was the next step. Our baby was found to be anemic. So we proceed with amniocentesis as these guidelines recommend for all these tests: karyotype, CMV, parvovirus, torch titers, all that. And then there are rare enzymes deficiencies like G6PD, pyruvate kinase deficiency, and all that will be considered at the end if nothing else is found. So this baby, the results were she was Rh positive with a negative antibody screen. Will immediately rule out what is called immune hydrops or red cell autoimmunization. She was rubella immune. The parvovirus B19 was negative, torch titers were all negative, the KB test was negative, and we have an MCA Doppler showing an increased peak systolic velocity with 2.4 multiples of the median, showing fetal anemia, and no answer of what is causing it at this point. So let's talk about a little bit of history. In the past, the diagnosis of fetal anemia was done by invasive procedures. These invasive procedures confer risk to the fetus and the mother, including preterm premature rupture of membranes, abruption, preterm labor, fetal or maternal bleeding, and even fetal death. What they used was the delta ODP450 to detect fetal anemia, and this was done by amniocentesis, or taking a sample of the fetal amniotic fluid. It was also called spectrophotometric measurements of the amniotic fluid for increased bilirubin concentration, and this is how we were diagnosing fetal anemia in the past. Now, after 2000, Mari published in the New England Journal of Medicine a study that proves a new non-invasive test that was effective on detecting moderate and severe fetal anemia, and this is how the MCA Dopplers were introduced. So the MCA Dopplers, basically when we have a peak systolic velocity greater than 1.5 multiples of the median, we diagnose severe fetal anemia, and this is used as a screening test. Mari wanted to know if this is accurate. He reported a sensitivity of nearly 100%, but for moderate or severe fetal anemia, but he had a positive false rate of 12%. And I think the reason of this is there wasn't a strong correlation between this and the hemoglobin concentration when the baby was not anemic or only mildly anemic. However, when the hemoglobin goes down or as the baby becomes more anemic, the MCA Dopplers and the level of the multiple of the media will increase, and the accuracy will increase as well. So coming back to our patient, she was referred to Texas Children's Hospital in Houston, Texas. She was first taken to the operating room for a choredocentesis and intrauterine transfusion. The first time she received 2 units or 2 transfusions. The very first time, the baby's hemoglobin was 2.2. They administered 11 cc's of irradiated leukocyte-poor CMV negative donor red cells with a hematocrit of 75%. The baby hemoglobin rose to 11.5 after this. Overall, during the next weeks, she received a total of 4 IOIs. At this point, we didn't know the cause of the fetal anemia. As we said before, the KB test was negative, the parvo serology and torch titers were negative, but the pregnancy appeared to be progressing well with the sequential transfusions. So during the 5th attempt, the hemoglobin was stable, so they decided not to transfuse. However, the baby became bradycardic, and they elected to proceed with an emergency cesarean section, and this was at 29 weeks gestation. Baby boy delivered at 29 weeks, weighing 12-20 grams. Upwards were 1 at 1 minute, 4 at 5 minutes, and 4 at 10 minutes after receiving multiple transfusions. Finally, after a couple of months, we had an answer to our question on what was the cause of this anemia. The baby had congenital thyroid agenesis of unknown cause, possibly unrelated to this fetal anemia. Also had borderline low carnitine levels, also I think unrelated to our fetal anemia. But the whole exome sequencing revealed a compound heterozygous mutation for the SPTA1 gene that causes hereditary spherocytosis type 3 and hereditary pyropoikilocytosis. And this was found as the cause of the baby's anemia. This is the result for the test. We have the gene SPTA1 that is inherited in an autosomal dominant or autosomal recessive way, but our baby had it in autosomal recessive way. And these are the diseases that they cause, these two genes. And the mom was found heterozygous for this mutation in the exon 22 and negative for the next one in the exon 49. The father had not been tested yet. So let's talk about a little bit of spherocytosis. This is the most prevalent cause of hemolytic anemia due to an abnormal red cell membrane. It is classified as a congenital hemolytic anemia. These membranes, there's a mutation in the membranes or the cytoskeletal proteins of the cell, specifically the red blood cells, and this protein plays a role in the structural morphologic stability of the cells. So when they are missing, the cells are like in higher tension, and this will increase fragility, and this will contribute to hemolysis. The abnormal proteins can be spectrin, ankyrin, band 3, band 4.2, and they are encoded by different genes. Like I said before, most of the cases of hereditary spherocytosis are inherited in an autosomal dominant disorder. However, 25% of individuals will have either a de novo mutation or an autosomal recessive inheritance, like in happened in our patient. This is hard to diagnose or to think as a part of our differential diagnosis because the parents wouldn't have any symptoms since they are also autosomal recessive and not dominant as the usual in this case. I only found one case in the literature search with a case similar like our case with an autosomal recessive hereditary spherocytosis in the homozygous states, same as our baby. Poikilocytes is just simply a type of cell or an abnormal shaped red cell that we can see here at the bottom in purple. These misshapen cells are mistaken by the spleen and for all or damaged red cells, and they are just taken and break down, and this contributes to hemolysis. So the other disease that the baby tested positive for was hereditary pyropoikilocytosis, and this is part of a group of disease that is called hereditary elliptocytosis. Basically, same thing is a disorder characterized by misshapen RBCs on the peripheral blood meal, and it will contribute to hemolytic anemia. This anemia can range either from absent to life-threatening anemia. And pyropoikilocytosis is the most severe form of elliptocytosis. The RBC morphologies, and this is what is unique of the pyropoikilocytosis, is that their RBC morphology will resemble the one that is seen in patients with thermal burns. And this confers a very unusual thermal sensitivity to the RBCs. It usually presents with neonatal jaundice from the hemolytic anemia during the neonatal periods, and this can continue through life. Coming back to our case, our baby had already a partial splenectomy, and at the beginning on his life, he received multiple transfusions. Now, after the splenectomy, this has not resolved the need for transfusion, and they are considering a possible bone marrow transplant. The mom got pregnant again. Her second baby was already delivered recently, and the child is unaffected. So they're trying to see if this second baby can be a donor for the first one, and if it will be a compatible donor to do a bone marrow transplant. In conclusion, hereditary spherocytosis is a very rare condition that, as I said, most likely or most commonly will present as an autosomal dominant presentation. The autosomal recessive form in the homozygous state, like our patient, is difficult to suspect in the fetus of the parents that are asymptomatic. and likely have a heterozygous state. Therefore, the importance of the MCA Doppler evaluation in babies with fetal anemia. That way, we can increase survival rates with this early identification. Thank you.